Thanks, Nolan. We'll move now into our next example of using the model for improvement around enhancing cancer screening. This project, we were working with a rural clinic. That clinic had 6 physicians. They did belong to a primary care network, and they did have previous exposure to quality improvement activities, though that was generally focused around certain projects or certain initiatives, and really no ongoing QI plan within the clinic or through their participation in the primary care network. There was some staffing attached to this clinic from the primary care network, which included a pharmacist and a registered nurse, both of whom were part-time. In the office, they were organized into dyads with a physician and medical office assistant, and there was a shared reception, billing, and administrative team that supported all of the physicians in the clinic. And this clinic was very interested in using some enhanced team-based care as a way to deliver service in their clinic. So initially it was, where to begin using a team and trying to enhance cancer screening. We brought it to a full clinic meeting to discuss the opportunity to improve cancer screening, and specifically that would be cervical, breast, and colorectal cancers. From that meeting, there were 2 physicians who expressed an early interest, particularly in using the EMR to improve screening. The other physicians were supportive of this activity, but not actively engaged following this meeting. So the next step this clinic took was to form an improvement team, and it was a relatively small improvement team with the physician lead or leads, depending upon scheduling, and the medical office assistant. And then the clinic manager would also attend to represent the broader support team. They set a meeting schedule of meeting weekly for 8 weeks to focus on their improvement activities. So they started with trying to be really clear about what it is that they were attempting to improve. And so we set a hard target of trying to improve by 25% by February 28th, 2012. And this was trying to achieve that improvement over what would be the course of a 2-month period, including the Christmas and the holiday break. So we knew that it was going to be ambitious, but they were prepared to dig in and get some of this work done. So we talked about, the team wanted to know how we know that the change is an improvement, and so they were going to conduct some process mapping of their current cancer screening offers within the clinic, and they agreed to do some chart reviews looking at moving their baseline, which was 62%, and then trying to achieve that 25% improvement, which was actually a little higher than the 72%, which is where they ended up, but that was their modified aim, was to go to 72% of the charts reviewed following that 2-month improvement period would demonstrate an offer of cancer screening. So the next step that this team went through is starting to look at what are their opportunities to improve. So identifying, what are some change activities that could be either strengthened, enhanced, or could be completely new. And they started with, just kind of creating a list. And so the first one that jumped to them was around creating rules in their EMR to identify patients who were eligible for cancer screening. They had previously seen the rules in their EMR system, but had turned them off because they were quite overwhelming and they really didn't know how to interact with them. But they thought that might be one option. The next option is around the role of the medical office assistant to include screening as part of their role and offering as much as they can to the patient. The PCN team, the nurse and the pharmacist, were also seen as resources within the clinic that could play a part in the screening process. They also recognized that some of the language around how screening is offered, or what language they use to support the importance of screening, could be a place where they would start around having some scripting or some common messaging to deliver to patients. They agreed that they needed to have some common, they needed to have an understanding of what the CPGs were for those cancer screens, and that they would have to agree that that's how they were going to choose to practice. Then they identified that should they be successful here, that they would fully intend to look to spread that to other clinical areas, specifically bone mineral density and some others. And then a full looking at fully implementing within the clinic by offering support to the other physicians to adopt any of the successful changes seen through this improvement team. So the first PDSA that this team wanted to try was around creating a rule within their EMR. And so in this case, the physician decided they were going to create one rule for one cancer, and the MOA would review 10 records following the rule being implemented to confirm that it is creating the correct reminder. And then the MOA would just record the number of correct flags as patients present. And if the flag was incorrect, she would just note what was the cause for that flag to be inappropriately recording. So they determined that their improvement team meeting was on Wednesday morning. The doctor was going to create that rule that day, likely after clinic ended, and that the MOA would test it on Thursday after the rules had run at 2 a.m. The next day they discovered that 8 of the 10 flags were correct, and 2 were determined to be incorrect due to the naming of the lab test. So there was a change in how lab studies were reported within the appropriate interval, and as a result, the rule that was created didn't incorporate some of the naming changes. So they decided to just adapt their rule to include both of those names and then retest on the following day. And so specifically the 2 names of tests that would test positive, which would include a positive screen for cervical cancer, were labeled PAP or gynecytopap within their EMR. And the MOA reviewed 10 more charts, and she found that 9 out of 10 records were correctly identified, and there was 1 record that indicated a patient was due for a PAP. But the patient was incorrectly recorded in the EMR as a female, so a demographic error that needed to be corrected. And so based upon that information, they concluded that that rule was working, and that the next week they would feel confident in beginning to have a discussion with patients regarding PAP tests. So so Sally would prepare either set up for PAP tests as a part of the visit, or be prepared to offer a follow-up appointment or referral to another agency. And so that was the plan for the next week to do that. And of course, they realized that doing a PDSA on a Monday was probably not the best idea. The clinic was quite busy, and so as such they chose to reschedule for the Tuesday and just called off trying to do any additional activity on that Monday. So on Tuesday, the MOA reviewed the PAP rules in the EMR, and the physician would then offer that as part of the care delivered on that day. So on that Tuesday, there were 6 active rules that appeared. The MOA prepared for the first patient, but the physician forgot to check the rule and consequently did not offer, and so their PDSA was canceled because it wasn't going in the right direction. And the action as a result of that was that offering PAP during the time with the physician might not be the best, and that the MOA could offer and rebook the patient, and thus ensuring that there was some follow-through on the rule being presented. The next PDSA, so how they continue to evolve and adapt that, was conducted on a Thursday where 3 active rules appeared. The MOA booked 1 patient for a follow-up appointment. 1 patient declined but expressed that she would follow up with another provider within the clinic. And 1 patient wasn't offered, the physician was running behind, and the rule just didn't get checked by the MOA. So based upon kind of how this process was working with the MOA and the ability to respond to the pressures within the office, they felt that this was a good approach that would at least move them towards an improving cervical cancer screening. So they were going to continue this and test for another week. So as you can see, the PDSAs were actually quite rapid, and setting that team up with the plan for their next PDSA based upon the information they gathered on the previous one was necessary in order to move this team through some rapid cycles of improvement, with the improvement team meetings happening weekly. And as a result, by the end of the improvement period, this was their flow map that they had created, which explained their process for cancer screening. So they did involve the PCN staff and the MOA in the cancer screening process. They were able to integrate all 3 cancers as part of their offer to patients, and really were able to deliver as much of the care during the visit, and really only rebooking resulted rebooking patients for PAPs. So without generating a lot of extra work for new appointments, they were able to offer this cancer screening with really a relatively small team to improve their cancer screening. So what did we learn with this clinic is that the model for improvement was an effective method for creating improvement, and that it could actually occur quite quickly. It was important that there was some measurement attached, even if they were small measures, and a way to collect additional information about the PDSA, and that predicting the outcome of the PDSA was very important, so that you can save time with those rapid cycles, or also in the case of thinking about planning a PDSA for Monday, we probably could have predicted that that might not have been a successful time for a PDSA. So having some of those predictions in place will be helpful. We learned that when you build capacity within the team around improvement, that they can then quickly spread that to other clinical areas. And so following the February 28th improvement time, this clinic has gone on to increase their screening list to about 6 other things that they now deliver as a part of that flow map. And again, process for scaling tests enabled spread to other providers. So, the negative components of the PDSAs weren't shared broadly with the team. They focused on what they learned from the negative pieces as well as the successes within their PDSAs. And that did create a bit of energy and a bit of motivation for the other clinicians to want to engage in an improvement process. And I think that's the end of our time, and I'll turn it back over to Nolan or Sandy and back to the audience if there are any questions. Thank you.